due to those barriers, people often hide conditions and disabilities, and they often do not request accommodations, even if they would benefit from accommodations due to their health condition. So that is a major problem with the system as is, and I think I think it's changing, but I think there's still a lot of room for improvement there.
Welcome to the Specialty Café, the podcast that helps you, medical students and residents, find your perfect specialty. My name is Cameron Wong, and I'm a current first-year resident at the University of Alberta in internal medicine, and I'm one of the hosts of the Specialty Café. I am here at the International Conference for Residency Education here in Quebec City, currently in my hotel room recording virtually, but I'm really excited to record this episode with a very special guest, Dr. Michael Quon. And so thanks so much for joining me, Dr. Quon. I'm very, very excited to chat with you about your job as a general internist, but then also about your extra duties that you've been able to pursue.
Yeah, thanks for that, Cameron. Happy to be here and happy to share my experience with your audience.
So maybe I'll just start off by asking you to tell me a few details about your background and what brought you to being a general internist at the Ottawa Hospital now.
Sure. So I'll explain just my educational journey. I find students and residents typically like that. So I started medical school many moons ago at Western, back when it was called University of Western Ontario, and graduated, moved across Canada to Vancouver, where I pursued my internal medicine core training. And then after 3 years there, moved back east to Montreal, and I completed my GIM fellowship at McGill. Following training, I worked in Montreal for about 2 years in a community hospital in Montreal, and I did a little bit of clinical work at the McGill University Health Center. And then there's more to the story, which we'll get into, but after that, I relocated to Ottawa, where I've been now for the last, time flies, about 7 years now. And I've worked in Ottawa at a community hospital, as well as the Ottawa Hospital, which is where I'm located now. For the last few years, I've been here exclusively.
So your medical training has brought you all over the country. You've certainly visited more Canadian cities than I think many other medical trainees or physicians have.
Yeah, I really enjoyed the experience moving around. Obviously, I mean, as you know, moving for your own residency, like there's challenges with relocating, getting to know the new systems and building a new network. But yeah, it's just a unique opportunity to live in different places and get to know people across the country and really sort of see a wide variety of health systems. So I really valued the experience.
Excellent. So yeah, I'd like to start off this episode by asking you about your job as an internist. And briefly, what is a general internist? Because this is a very elusive question that I have to explain to my own family members quite frequently as well.
Yes, it's a common one we have to address in the hospital all the time. The way I describe it is general internist is a medical specialist who cares for a wide variety of clinical conditions and patients, but the most common, and there's a wide variety of practices among general internists, but I would say some core areas where GIM does a lot of work is in hospital care of acute hospitalized medical patients. So people who are hospitalized for any non-surgical reason, typically in the form of organ dysfunction or infections. Separate to that, though, general internists some general internists pursue outpatient practices as well, and the outpatient practices are quite varied because GIM covers a wide variety of organ systems, so people can sort of choose to specialize more in the outpatient setting or kind of maintain a more general practice. So, and hopefully that answers you and your parents' question for next time.
And hopefully many other listeners as well. I started this recording for this podcast when I was in second year of medical school, and at that time I had no idea what general internal medicine is was. Now I have a better idea, and I think like what also makes GIM stand out to me is like the multi-system approach to problem solving. You have like organ dysfunctions of essentially any organ that can end up people on a GIM ward. But when there's multiple things going on, I think that lends itself very well to the expertise of someone like you.
Yeah, thank you for filling in that, Cameron. That's totally a big part of our work is multi-system care, comprehensive care. Um, that's part of the work that really drew me to the practice. And yeah, we're well situated to care for lots of types of clinical conditions in the hospital.
And going on, could you briefly tell and talk about what a typical day might look like for you at the Ottawa Hospital as an internist? Recognizing, like you mentioned, there's the inpatient side of GAM, but there's the outpatient side of GAM. I'm sure some days you're working with learners, some days you're not. And then as well, maybe some days you're participating in advocacy work for physicians, like we will talk about, foreshadowing to that. So difficult question, but I'll leave it to it.
Sure. Yeah. So I mean, totally, and you're totally right in that all generalists have slightly different practices. But my own clinical work is so there's no sort of typical day, but I would say that we have service weeks where we are doing um, inpatient. For me, I generally do inpatient internal medicine care. So that's admissions from patients to the hospital, and then care for them while they're hospitalized, and then arranging their discharge. These weeks are, for us at TOH, are 7 days in length, weekend and weekdays. And we have different types of weeks. One type of service week is CTU, which is clinical teaching unit, and that's with a team of medical students and residents. And as the staff physician, you're the attending, supervising a care, and the most responsible physician, but you're overseeing the care of the medical learners. And then separate to that, we have non-teaching inpatient service at the Ottawa Hospital, which is, either on your own or with one resident to care for a smaller number and typically less acute and complex patient list. And that's the way it's organized at the Ottawa Hospital, but there's definitely different approaches to how this inpatient care is delivered in different hospital settings. So that's sort of my inpatient work. And then and then outpatient, I do some clinics, and for me, my focus in the clinic setting is what we call rapid referral clinics, which are designed to see outpatients who need internists in a time sensitive way. So people seen in the ED, people seen post hospital discharge, acute sort of patients from the community referred by their family physicians. And so we try to see them all in a timely way. In the clinic setting, that's something I do on my own as well as in supervision of residents and trainees. And then finally, I also take on work with a group of my colleagues, and we do what's called vascular medicine clinics, where we provide, medical care and optimization for typically high-risk cardiovascular patients, and do the comprehensive medical care from that side of things. So those are my three areas of clinical work, and I'll stop there and let you follow up.
Of course, yeah. Your clinical duties, similar to a lot of other internists I've talked with, are varied, of course. You mentioned like lots of inpatient work. You do the rapid access clinics, which are excellent. I think seeing people in the emerge so far, like in residency, there's been patients where if maybe like there is a more like well established like rapid access system, maybe they could have avoided admission, like they'd be able to see more like appropriately in clinic. So like that certainly helps to offload like the hospitals and make sure that like acute beds are used for like acute conditions. So like really important work as well. And then you have the preventative side too. So like yeah, very comprehensive care, as I think all internists are well equipped to provide. So now, having chatted a little bit about your job as a general internist, I think it's very worth giving light to the other side of your duties at the Ottawa Hospital and as a physician advocate too. Um, so, for the listeners who aren't aware, Dr. Quon has done an episode with the Royal College already. It's on the Specialty Matters podcast, and there he talked about his experience as someone with a lived experience with a traumatic brain injury, and then about his work as a physician advocate too. And so I do want to touch on this, but also with a learner lens this time to kind of follow up, because I think this work is super, super interesting, Dr. Quon. If we can, yeah, discuss that.
Yeah, so briefly, I was not attuned to issues around disability at all during my medical training, and was in a road cycling crash right at the end of my residency, and suffered a moderate traumatic brain injury, which changed my career and life entirely, and showed me a lot of challenges and opportunities for like system improvement. When I was returning to work with disability, and has motivated me to really take a lot of advocacy and leadership in this space.
And so some of the ways that that's kind of taken shape over the past few years are like your involvements with like hospital leadership. I believe you're also involved with a project with the Royal College too to establish, was it community? You'll have to remind me the name of it.
Yeah, yeah. So I part of what we identified, myself and a lot of peers, physicians living and working with disabilities across Canada, is that there's often a lack of structural support and community, and so the Royal College Canadian Aid and Action Fund supported a grant that I led, which was to basically support this community of practice that we launched virtually just this last year. So this is a community of physicians and medical learners across Canada who live with disabilities and or chronic conditions, and we've named the community altogether Physician Health Inclusion, which is to try to be as inclusive as possible for anybody with health challenges, whether or not they identify as having disability or not. They are welcome to join the community and learn and share and support others, and hopefully, catalyze some advocacy and ongoing opportunities for improvement.
Now, this type of advocacy that you're describing, it's advocacy for physicians. And before we recorded this episode, we were talking about how advocacy, in the sense of the CanMeds role that we're taught, is often thought by learners to refer strictly to advocacy for patients. And so, like patient advocacy at the government level, patient advocacy at the local level within the hospital, making sure patients have enough resources. But as I understand, a lot of the work that you've done is focusing on like highlighting voices from physicians and physicians in training who have chronic conditions or disabilities, and recognizing that physicians are people too and patients as well, and they need support. So it's a different lens than the one that's traditionally taught in curriculums.
Thank you for highlighting that. Yes, it's something I'm passionate about, and I've done a lot of work in. And I'm not alone. There's a lot of physicians who have faced discrimination or faced ableism in the workplace, and feel quite passionately about how it needs to be better. That's actually quite a common experience. I've been fortunate to get into sort of a clinical position that worked well for me, and has been, I've received ongoing accommodations for in my workplace. And it's allowed me to pursue advocacy, and that comes in all forms, at the institutional level, medical associations, um, CMPA, Royal College, like all these. I've gotten to know leadership in all of these national and provincial organizations. For one, to really just raise awareness, I felt like it was really important to, bring this issue in medicine to the forefront, and let leaders know that this is an issue. And it's been challenging, I will say, at times, because you don't always get the responses you want when you're having advocacy roles. But at the same time, it's opened up a lot of opportunities for me, and I really felt like it's been a valuable part of my career so far. And I would encourage, all students and residents to also help advocate for changes to the medical profession that can make our workforce more inclusive and accessible for all of us.
I think it's worthwhile discussing some of like the concrete like areas of need in accommodation, especially like at the learner level. I know there's a lot of listeners on this podcast who are as early as first year medical students who have never rotated through a clinical rotation. There's also med students who have, and there's also residents who have had intensive experience with that. So I'm sure you have a lot of experience in chatting with like people of different stages and like what there needs to be done, what has been done. What would you say are some like examples of lack of accommodation that like come up as themes throughout, like let's say even pre-clerkship and clerkship and residency?
I would say the biggest, well, it's hard to say the biggest, but some of the core areas that we can improve are one, stigma. So people who have disabilities may or may not even acknowledge they have disabilities, and that's a lot of stigma and internalized ableism right there. But it comes from society and medicine. There's a lot of structural ableism within medicine itself, and so people are sort of taught that you have to do work in a full time without accommodation capacity. So this is leading into one of the second barriers, is that people don't even really know their rights. Often med students and residents are not that aware of the fact that they can seek out workplace accommodations. So there's a bit of a lack of awareness of rights to accommodations. There's the stigma of not wanting to request accommodations, and I think those are two important areas that, especially for medical learners, we need to like really focus on and work against, because due to those barriers, people often hide conditions and disabilities, and they often do not request accommodations, even if they would benefit from accommodations due to their health condition. So that is a major problem with the system as is, and I think I think it's changing, but I think there's still a lot of room for improvement there.
And like you talked about on the last Royal College episode with Specialty Matters, this kind of stigma is baked into the culture of medicine and is still, I would say, taught as like a bit of a hidden curriculum to med students. When I started clerkship, I was taught that it would be best if I'm available, affable, and like essentially like able to do work. And a lot of that culture of medicine glorifies and raises up this idea of a physician who is a doer, is someone who can say yes to doing things, is someone who can do the best for their patients, like do more, and do more for the team, push themselves. And I think the kind of runaway consequence of that is that when you, for example, have a disability and for whatever reason are unable to meet those demands, then you're seen as a problem in many circumstances. And I think that's really at odds with how things should be. And yeah, like you mentioned, like highlights that we have a long ways to go.
Well, this is exactly it. This culture of physicians who are, somewhat like superheroes, the glorification of, working without sleep, working without eating, working without taking breaks, working when sick. This is kind of baked into the historical lens of what a doctor is. And obviously, there's still influence of that towards med students and residents. And then there's this ableist undertone that if you can't hack it, if you can't do it in its full throttle capacity, there's some, there's a, even if it's not said out loud, you might feel like it's a weakness or you're a lesser in some capacity. And unfortunately, this doesn't add up because, doctors, in fact, are human beings, and doctors, like all other human beings, experience disabilities, and disabilities come in all shapes and forms. Just for your learners, disability includes, the ones that are visible, the sort of outward ones that are seen, but more commonly there's invisible disabilities, and they can come in the form of chronic health conditions, mental health conditions, neurodiversity, as well as the more commonly understood mobility and sensory impairment and that. But I think it's important to really highlight that disability is quite inclusive, and many medical students and residents live and work with disabilities. We looked even before the podcast, and the best data comes from the US. And it's in the order of 4 to 5% of the best survey-based data that they have from the U.S. Of med students report disabilities. So it's not insignificant, and it's a bit hidden in terms of the culture of medicine.
I think you even previously quoted that somewhere along the lines of 50% of residents with disabilities who would benefit from accommodations don't end up pursuing accommodations because of this idea that they would be seen as like the problem residents, essentially, that they're being an undue burden. Whereas you mentioned like people are entitled to workplace rights to complete their job duties, in fact.
For sure, and there's the stigma, but also additionally to that, in that study, they identified that people didn't know the process. People didn't really even understand. They may have not understood the rights to accommodations, but then they would also not really know the process to get accommodations. And when you're in that scenario, I've been there. Sort of, it's difficult to put yourself out there and self-advocate for accommodations, especially if you don't have a good understanding of the process.
So we've talked about, I guess, what accommodation, lack of accommodation can look like and the effects of that. But with all these initiatives that you're working on, I'm sure like you've seen examples of progress, examples of like conversations that have led to good. What are some like evolving solutions that you think are in the works or that you've seen so far that are particularly relevant to like learner stage physicians in training?
Yeah, that's a great question. This is so that there's a lot of progress going on. I'll highlight a few. So one of them is there's growing support. So this is I've already mentioned the community practice physician health inclusion. This is under the sort of broader umbrella of the Canadian Association of Physicians with Disabilities, which has additionally a trainee specific group of students and residents who live and work with disabilities. And we'll share links after, but I would encourage anybody who this speaks to consider joining both our community of practice, which includes staff physicians, but also this trainee group if you're more wanting to be connected with like-minded peers. And I think the support right up front, trying to connect with others who are in similar situations, and learn from other people's experiences helps you understand the benefits of accommodations, the normalization of the fact that there's lots of people across Canada living with disabilities in medicine. And yeah, it just makes you feel less isolated through the process. And I think that's really an important place to start, because I think you can then um, learn from a lot of other people who have been in similar situations.
So, just as we're wrapping up here, Dr. Kwan, hearing about your story, having experienced a traumatic brain injury, to getting more like knowledgeable about what there is for accommodation, what there isn't, and then making your way into advocacy, it made me like think about all that you've done, but also that like, well, as someone as a junior learner, I have no idea how to get to where you are today in the space that you are to advocate and what that path looks like. And so, like, what was it like, I guess, progressing to what you are doing now? Can you talk a little bit about that?
Sure. Sure, Cameron. So I would say I think it's easier now. So my own experience, over the last decade, I really did feel like I was creating my own path through this work. For sure, I connected with other physicians with disabilities, but I was also trying to understand where I could have impact and where I could, have influence in the system. And I've learned a lot through that, and also through the journey, I've thankfully connected with many other physicians across Canada who are working in this space. So I do think now there's mentorship available. So we have these community of practices that I've already mentioned, that where you can connect with people above your level of training. There's also a growing number of projects, leadership opportunities, research, quality improvement. Like there's like a growing list of ways that you could get involved in the work itself, and this applies to learners who live either openly or silently with disabilities, or other learners who are interested in this work. We definitely have opportunities to contribute to projects and network, and learn from physicians who are more senior to you in the work. And I think through that experience, you can really get a feel for what this work is like, contribute to some projects that can help you in your career growth, and also start building a network within the medical community that can hopefully help you in your overall career as you progress.
So, in making it to where you are today, really, it sounds like you're describing an organic process that you had to like search out for yourself. It's not like this wasn't a defined path where like research where if you want to become a clinician investigator, you start by joining a lab and you network and you like know these people and you publish some papers. This was something where you realized a need, but you characterized it further because like no one had really done the things that you are before, so you talked to people who had lived experiences like you, and you further like found what other people need as well, you amalgamated them, you built a community for like physicians and then physicians in training to like group together and discuss. So Yeah, it's very inspiring. It's inspiring stuff.
Thanks, Cameron. I think it is encouraging though, because like I said, it's not full trailblazing anymore. Like there are lots of physicians now doing work in this field, and so you can, I think you can, you know, tag on to people's work and contribute sort of in the more traditional way now. But of course, this is not. This is more with an advocacy lens than just pure kind of clinical or research-based academic work. So yes, it definitely helps a lot if you believe in the cause and really, you know, are ready to sort of help push for improvements in the movement.
Very excellent. So, coming to the end of this podcast episode, we've covered a lot. Initially, just about your job as an internist, but then more so like the like expansive amounts of like work that you've done in like advocating for physicians informed by like your own lived experience with traumatic brain injury. But bringing this all back, I asked this question on essentially every single episode, and it's the last question. But because this is a podcast for learners, especially early on in medical school and late during medical school or in residency, as like myself, what's a piece of advice you would give medical learners who are just starting their career in medicine if you had to give a piece of advice?
Yes, it's always hard to decide what's the top advice to give. But tying back to, I mean, this applies to all your learners. Like tying back to my own experience, I think we are as physicians with lived experiences of disabilities unique in that we have the patient perspective as well, and that's an value added to the profession to have that perspective. And my own, I mean, I'm talking a lot about advocacy for physicians, but my own perspective as a patient and a rehab patient really helped inform like my values as a clinician and as a teacher. And I think it's important to highlight, I think, for all students and residents that you are a critical piece of the healthcare team. And even if you're not making the, you know, always making the clinical decisions, you are able to have a lot of influence and care for your patients. And I think this is not always rewarded or evaluated in the traditional medical education evaluations, where we talk about clinical decisions, knowledge, efficiency. Those are all important, but you also are building your craft at caring for patients and communicating with patients empathically and with families. And those are really core skills that are remembered by patients and their families forever. So it's just to highlight that that part of being a doctor is um, absolutely essential to being the type of doctor I think you want to be. And I think trying to just keep that at the forefront as you go through your medical education, even if the system is not evaluating you on it, I think is really important to try to remember the type of doctor you're trying to be and the type of care provider you're trying to be for your patients.
This concept of paying attention to more of like what you would call like the soft skills of medicine, like excellent bedside manner, like relating to patients, building rapport. It kind of makes me think of a quote. I'm sure it's a quote from someone, but it's like that people will remember less of what you did, but more so like how you made them feel in that like giving time to a patient and being able to build a relationship with them, that in itself is like a medical therapy and treatment as much as like a medication can be in many cases.
Absolutely, and not only that, it's a rewarding part of clinical practice. Once you're out of the training environment, you might be getting to know patients more in a longitudinal way, And it is quite rewarding for all clinicians, I think, to have those types of relationships with patients. And yeah, I think, I think a lot of learners know this value. I think it's just important to sort of bring it to the forefront and keep it as an important intention as you're progressing through training.
Absolutely. Well, yeah, I guess that's all the time we have for today, Dr. Quon. We could have talked for much longer, certainly, but I'm really grateful that I had the chance to characterize in the small, like a small part of everything that you've done, who you are as like in your professional identity. Because I think you have a very inspiring story, and you've used your identity as someone, as a patient, to advance care for patients and also advance what's available for doctors in terms of accommodation and support that way. So I very much thank you for the chance to chat with you, and I hope that all of our listeners enjoyed as well.
Thank you again for inviting me, and yeah, happy to hear more from any learners across Canada through a community of practice. So please come join, and we hope to see you there.
Excellent. Well, that brings us to the end of this episode. Thank you so much for tuning in to the Specialty Cafe again. My name is Cameron Wong, one of the hosts with the Specialty Cafe, one of the internal medicine residents at the U of A. And yeah, continue to tune in for more Specialty Cafe episodes to come. Thanks so much.